I'm Matthew James, a nephrologist and health services researcher at the University of Calgary. On behalf of my co-authors, I'm going to present our trial, The Effect of Clinical Decision Support with Audit and Feedback on Prevention of Acute Kidney Injury in Patients Undergoing Coronary Angiography, a stepped wedge cluster randomized trial, also called the Contrast Risk Reducing Injury Sustained by Kidneys trial. This trial was funded by Alberta Innovates. Results were published in JAMA in 2022, along with an accompanying editorial. The design of the intervention and trial was published earlier in the Canadian Journal of Cardiology in 2019. Acute kidney injury and cardiac catheterization is common, costly, subject to substantial variation in practice, preventable, and important to patients. The figure on the right shows that with increasing severity of acute kidney injury, patients experience higher mortality, risk of end-stage kidney failure, and cardiovascular and kidney hospitalizations. Acute kidney injury is the most common serious adverse event of coronary angiography and intervention, with an estimated attributable cost of $150 million annually in Canada. Our overarching objective was to reduce the risk of acute kidney injury, thereby improving the safety of coronary heart procedures and optimizing outcomes of vulnerable people with heart disease. Several observational studies have suggested that reducing the volume of contrast media, which is used for imaging blood vessels during these procedures, may reduce the incidence of acute kidney injury. These studies have developed models to identify safe contrast limits that are individualized based on a patient's characteristics. In observational studies, these have been shown to be associated with lower incidence of acute kidney injury. The administration of intravenous fluids is also an important prevention approach for acute kidney injury. Prior to our trial, a number of small randomized controlled trials indicated that administering IV fluid volumes according to hemodynamic measurements was a more effective strategy for reducing the incidence of acute kidney injury. These include measurements such as the left ventricular end diastolic pressure that is commonly collected during cardiac catheterization. Prior to our trial, we observed large variation in the use of prevention strategies for AKI in Alberta. The figure on the left shows a large distribution in the amount of contrast volume provided in each procedure by 36 physicians across the province of Alberta. We observed that 28% of the residual variation in contrast volume in Alberta was attributable to physician factors after adjusting for patient and procedural differences. The figure on the right shows that contrast volume does vary by site in the province of Alberta, however, did not vary by the risk of acute kidney injury. The highest risk patients being seen in the columns on the right side of this figure. This illustrates that patients at high risk of acute kidney injury were not more likely to receive strategies that would lower their risk of acute kidney injury, suggesting opportunities for improvement. Thus, we designed a multifaceted intervention for prevention of acute kidney injury. The red box illustrates the first component of the intervention, which was the automated identification of patients at risk of acute kidney injury using a multivariable model. The gray box illustrates the use of embedded clinical decision support to provide invasive cardiologists with guidance on safe contrast limits. The yellow box illustrates the use of tailored recommendations for hemodynamic guided IV fluid protocols, also for prevention of acute kidney injury. And the blue box on the right illustrates the measurement of processes of care and acute kidney injury incidence that was reported to physicians. These interventions were promoted through educational sessions, a point of care, computerized clinical decision support system, and an audit and feedback process provided to all physicians who performed these procedures across the province of Alberta. Our implementation principles were based on establishing trust and buy-in from invasive cardiologists practicing in the province of Alberta, using clear, clinically actionable guidance at the point of care to promote uptake of prevention strategies, achieving seamless integration of these tools into clinical workflow, and establishing accountability for AKI prevention with ongoing audit and feedback. The first component of our intervention was an educational program. This was CME accredited and delivered to invasive cardiologists when they began receiving the intervention, delivered by a local site champion, an invasive cardiologist at each center who was familiar with the project. The second component was a point-of-care computerized clinical decision support tool implemented in a clinical information system active in all cardiac catheterizations across Alberta. This system, called Approach, the Alberta Provincial Project for Outcome Assessment in Coronary Artery Disease, is also linked to a registry that measures care and outcomes for patients receiving coronary angiography and PCI. One component of this tool was the implementation of a prediction model, shown here. Staff in the cardiac catheterization units were trained on how to complete collection of the variables in order to execute this model and to complete the model in the Approach system prior to procedures. Outputs from these models were then presented in the cardiac catheterization units at the point of care. This included information on the risk of acute kidney injury, what a safe contrast limit would be for an individual patient, and what a hemodynamic IV fluid administration protocol recommendation would be for that patient. This information was reviewed during a timeout in the cardiac catheterization facilities prior to each procedure. Finally, physicians received an audit and feedback report on their performance every 3 months. This audit and feedback report showed their performance compared to other physicians in their site and across the province. The audit and feedback reports reported on 3 metrics: the percent of their procedures where they exceeded the safe contrast limit, the percent of their procedures where they did not deliver the optimal IV fluid volume, and their acute kidney injury incidence. The trial evaluated in this intervention was a multi-center stepped wedge cluster randomized control trial that was carried out in all 3 sites where cardiac catheterization is performed in Alberta. The study population was physicians, including all invasive cardiologists practicing in Alberta at the time. The patients included were over 18 years of age, receiving non-emergent coronary angiography or percutaneous coronary interventions, not receiving dialysis, and had a predicted risk of acute kidney injury over 5% using the prediction model. The intervention, as previously described, involved education, computerized clinical decision support, and audit and feedback delivered to invasive cardiologists. The trial was designed with a primary outcome of acute kidney injury based on the kidney disease improving global outcomes serum creatinine criteria. Secondary outcomes were processes of care, contrast volume, and intravenous fluid volume administrations, and clinical outcomes of the number of days in a hospital bed following procedures, major adverse cardiovascular events, and major adverse kidney events. This figure shows the stepped wedge cluster randomized trial design, and you can see by these colors why this design is called a stepped wedge. The stepped wedge design involves randomizing here clusters of physicians to time periods where they move from the control or pre-intervention period to begin receiving the intervention. Our trial involved 8 clusters of physicians defined by their practice location and practice group. Periods were 10 weeks in duration, and every 10 weeks a new cluster would be randomized to begin receiving the intervention, such that by the end of the study, after 8 periods of implementation steps, all cardiologists and their patients would be exposed to the intervention. Here are the characteristics of the trial cohort. The mean age was 70 years, and the majority of participants were male. 66% of procedures were done for an indication of acute coronary syndrome. Common comorbidities were heart failure in 33%, diabetes mellitus in about 60%, and chronic kidney disease in about half of participants. The median predicted risk of acute kidney injury in the trial cohort was 6.7 to 6.8%, and the fluoroscopy time, a measure of the complexity of procedures, was similar at 7.7 minutes in each group. This figure shows the incidence of the primary outcome acute kidney injury. The blue line shows the incidence across the duration of the trial in the intervention group, while the red line shows the incidence across the duration of the trial in the control or pre-intervention group. The incidence of acute kidney injury was 7.2% in the intervention group versus 8.4% in the control group. In time-adjusted models, the odds of acute kidney injury was reduced by 28% with the intervention. This corresponded to an absolute risk reduction of 2.3%. Findings were consistent in multivariable adjusted models that also adjusted for age, sex, diabetes, heart failure, baseline estimated eGFR, and procedural indication. Results were consistent for the primary outcome of acute kidney injury across a number of subgroups defined by age, sex, procedure type, diabetes, heart failure, chronic kidney disease, and the predicted risk of acute kidney injury. Secondary outcomes included safe contrast limits and intravenous fluid administration. There was a 23% reduction in the odds of exceeding the contrast target with the intervention, and a 32% reduction in the odds of administering insufficient intravenous fluid according to the LV-EDP base targets. Secondary clinical outcomes of the trial included major adverse cardiovascular events. These were similar between the intervention and control groups. The odds of major adverse kidney events were 17% lower with the intervention, although this difference did not achieve statistical significance. In summary, we found that an intervention combining education, clinical decision support, and audit with feedback resulted in less contrast dye use, greater IV fluid administration, and reduced the incidence of acute kidney injury following coronary procedures. This intervention is feasible in any system with electronic clinical information systems at point of care, informatics resources to audit and report on care practices and outcomes, and a culture of quality improvement to support processes to improve care. The number needed to treat for this trial was 44, meaning that one patient could avoid acute kidney injury for every 44 patients receiving a coronary procedure. If 1 in 5 AKI events can be avoided as suggested by our trial, and there's over 1,350 of these episodes per year in Alberta, with a cost attributable to AKI of $5,530 per episode of care, this intervention has the potential to save $1.5 million every year. This is twice the cost of implementing and evaluating this program. Additional long-term cost savings could be achieved if maintenance kidney replacement therapy is also reduced by this intervention. I'd like to acknowledge our partners in this work, particularly the staff and care providers in the 3 cardiac catheterization centers across Alberta, in the Libin Cardiovascular Institute, the Mazinkowski Alberta Heart Institute, and the CK Huey Heart Center. Thank you.